Hello and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss delayed or absent orgasm. Now, most guys are familiar with premature ejaculation, a condition in which men achieve an orgasm and ejaculate too soon. But what about guys who take too long to achieve an orgasm or can't achieve one at all? How long is too long when it comes to reaching an orgasm? What causes delayed or absent orgasms? What are the treatment options and how well do they work? To answer these questions and many more, we turn to a true expert. Dr. Alexander Pastuszak is Assistant Professor of Urology at the University of Utah School of Medicine. Dr. Pastuszak earned his undergraduate degree at Yale University and then went on to complete his MD and PhD degrees at the University of California, San Francisco. He then both completed his urology residency and a fellowship in male reproductive medicine at Baylor College of Medicine. Dr. Pastuszak has authored over 80 peer-reviewed articles and numerous book chapters on men's reproductive and sexual health. And he's the editor of the textbook entitled Management of Sexual Dysfunction in Men and Women, an Interdisciplinary Approach. He has also been the section editor for the journal Sexual Medicine and Current Sexual Health Reports, and is associate editor of Sexual Medicine Reviews, the Journal of Sexual Medicine, and Fertility and Sterility. And now, without further ado, I bring you a conversation with Dr. Alexander Pastuszak about delayed or absent orgasm. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about the sensitive topic about delayed or absent orgasm. Now, a few podcasts ago, we had a chat about premature ejaculation, a situation where men ejaculate or reach orgasm too early during sexual activity. But for some men, the situation is quite the opposite. It takes them too long to achieve orgasm or to ejaculate, and for other men, they can't reach orgasm at all. Now, at first blush, for some guys, they may think this is not so bad. I can last longer during sexual activity. My partner will be happier, and I can be that sexual Superman. But in reality, that's not usually the case. Delayed or absent orgasm can actually lead to a lot of sexual dissatisfaction. It can lead to pain or discomfort for the individual or their partner, can lead to problems with sexual relationships, and eventually can even lead to avoidance of sex altogether. So what really defines delayed orgasm? What causes the condition? Is it treatable? And if so, how? In order to answer these questions and many more, we're very fortunate to be joined by Dr. Alexander Pastuszak. He's an expert on men's sexual health. Dr. Pastuszak, welcome to the program.
Oleg, it's wonderful to be here. Thanks for having me. A great topic to discuss today.
Absolutely. I know the guys out there, having received a lot of email about this, I know the guys out there are very interested, and there's a large contingent of guys in this side of the equation. Now, before we jump into the topic at hand, one thing I like to do is kind of acquaint the guys with the expert. And one thing I like to ask is really what inspired you to become an expert in male sexual health?
Yeah. So, Oleg, I think you and I are both urologists, so we sort of picked the right field there. But
Right.
I went into men's health for really a couple of reasons. One, it's surprising just how much you can help a man when dealing with these sorts of intimate and sensitive problems. And I'll just go ahead and say it. Guys don't like to talk about sex very much. Guys don't like to talk about fertility very much, but these are things that are very much on all our minds, including mine, and I would proffer that they're probably on yours as well. And so when you help somebody with these types of issues, they can be helped as much, as if you're curing their cancer, right? So that's one reason. Another reason is that, look, I'm a physician scientist and entrepreneur, right? So I do R&D on these types of things, and this is an area where innovation is really needed, right? There's not a lot of people innovating in this space. It's something that I really enjoy as part of the work that I do, and I think that that's one of the most meaningful things that I do is research in the men's health space around problems like these and other problems that really affect men. So those are two big reasons that I went into this space.
Well, it makes a lot of sense. It looks like we definitely have the right doctor on the podcast for this particular topic for sure. So thank you for that. And obviously you have a lot of passion for it, which is important. And to your point, that's a big reason for this podcast is that a lot of guys feel uncomfortable going to the doctor. And hopefully this conversation will empower a lot of them, at least to have the basic information to have a meaningful conversation about the problem. Now, before we dive into the topic, I want to kind of do a little housekeeping and define some terms so that everyone's on the same page. Because on a previous podcast, we kept talking about premature ejaculation, and now we're talking about orgasm. So the first quick question out there, we'll throw you a softball, right? What is the difference between an orgasm and ejaculation? Is it the same thing?
No, they're actually two separate processes. But, a lot of times we talk about them, even as physicians, as one and the same thing, because in men, they typically happen concurrently, right? So the strict definition of orgasm and ejaculation is effectively orgasm is the sensation that you get with sexual climax, whereas ejaculation is the actual physical process of expelling semen from the urethra and penis, right? But they are, for all intents and purposes, tied together in so much that most men experience orgasm and ejaculation together, right?
Mm-hmm. Now, the question then is, excuse me, the question is, can men actually experience an orgasm without ejaculating?
They absolutely can. And, to be honest, in my line of work, I often see guys who, particularly after a procedure or some sort of trauma, accident, they'll have orgasms, but then they're not ejaculating, right? And that kind of freaks them out. So there are definitely situations in which you can have orgasm and not have ejaculation. There are also situations in which you can have ejaculation and not have orgasm, although those are much less frequent. Coming back to the original set, cases in point are, if a guy has a surgical treatment for, or even medicine for enlarged prostate, right? Many times you'll have what's called retrograde ejaculation, right? Where you ejaculate into the bladder, but you're not actually expelling the semen out. And, guys don't necessarily expect that. And when they have it, they're like, oh my God, doc, I'm not ejaculating. What's wrong with me? I mean, it felt really good, but nothing came out. So there are definitely situations like that.
And so that being said, most guys equate an orgasm with the feeling of ejaculation, with the semen coming out. So if it's not actually the ejaculation causing the orgasm, what actually causes that sensation, that pleasurable sensation of an orgasm in that case?
Yeah, look, it's, the bottom line is it comes from your brain, but your brain takes the inputs from your genitalia and other arousal areas. For example, for guys who get stimulated through the prostate or through anal sex, that stimulus can come from there. Otherwise, it can come from the penis. It can come from other areas too, albeit those are the most common, sensory inputs to the brain for it to be able to process and get to the point of orgasm, and as a result ejaculation. But those are the main ways you get there, right? We don't really have any good way. We know to an extent, not super well, what the sort of central causes of orgasm and ejaculation are, right? So in a world where this research would be more advanced, we'd be able to potentially stimulate orgasm and probably ejaculation as well, just through the brain, but we're not quite there yet. So primarily it comes from the outside for now.
Got it. Got it. Okay, so now the $5 million question. What every guy needs to know and is afraid to ask. What is considered a normal time to an orgasm or ejaculate? Because I mean,
That
this is locker room talk 101, my friend. So what is that normal time?
so the sort of median time or average is about 5 minutes,
Okay.
right? And so we'll just very quickly. I know this is about delayed ejaculation, anorgasmia, etc. But just to sort of level set. So when we're talking about premature ejaculation, as you talked about in one of your prior podcasts,
Mm-hmm.
you're talking about men who ejaculate in less than 1 to 2 minutes and who
Mm-hmm.
are uncomfortable with that, right? Because those are the two parts of that definition, right?
Right.
It's the timing, but it's also the discomfort or unrest that comes with that. For delayed ejaculation, in contrast, these are men who take more than 25 to 30 minutes to reach ejaculation/orgasm. That's the definition of delayed orgasm, right? And just like you opened up this discussion about, I mean, a lot of guys would be like, Eureka, I love this, right?
25 minutes.
Holy cow. I mean, we'd be rock stars in our own right.
Right.
But the reality is the second part of that definition is that distress piece, right? So in a man and or a partner that has distress that arises as a result of this delay from this typical 5 minute period, that is the guy that you see typically in the clinic or who is sitting there at home silently, distressed about this, thinking, man, I really wish that this weren't that big of a problem for me.
Got it. So speaking of that guy sitting there saying, okay, Dr. Pastuszak, you know what? This definition seems to fit me. I'm at home. I'm really bothered by this. Is really ruining my sex life. And now I'm starting to worry. What's causing this? Am I in trouble? Do I have some serious health issues? What is causing this problem?
Yeah, it's a good question. And I'll be honest, oftentimes we really don't know. This delayed ejaculation and orgasmia, this is probably one of the least understood and hardest to deal with problems that clinicians such as myself and in general the clinical world come up against. And look, there are a variety of potential causes. They range from drugs, which are that's the easy one to take off the list. So, men who are on certain antidepressants like SSRIs, men who are on other drugs. And look, there's a list of probably 30 or so drugs, maybe more. I don't know them all off the top of my head, that can increase how long it takes to orgasm or ejaculate. Those are the easy ones to diagnose because you get that historically, and then you can kind of run down the list and sort out, hey, when you started taking this medication, did you notice that this problem arose, right? More sort of insidious, are some of the sort of physical or potentially psychological causes. And again, the science on this isn't perfect, right? So there's some evidence that supports a low testosterone level contributing to this, or a high testosterone level even in some cases. Thyroid dysfunction, when you look at the sort of neurochemistry of orgasm and ejaculation, the main drivers of these processes really are testosterone and dopamine, right? And the inhibitors of these processes, which is why some of these drugs are a problem, are prolactin and norepinephrine, right? SSRIs prolong how long norepinephrine and serotonin sit around, right? And these are two big inhibitors of these types of processes. So, I can talk in terms of big classes of problems that may contribute, but we don't fundamentally still fully understand the problem here. Just to sort of wrap up on this point, in terms of other issues that may cause problems here, there's neurological insults, like we just talked about, the sensory system to the genitalia. If that's disrupted through an accident, a trauma, even a surgery, then that can cause problems with anorgasmia or delayed ejaculation. And then there are psychological issues, right? So if there are aspects about performance or relationship stress or other things that that a man and or his partner would contribute to, would internalize, and psychologically cause issues with the comfort needed to get to climax, all of these things can contribute. So it's really the message here to listeners is that this is likely a multifaceted problem that can arise because of a number of reasons. It's not hard to diagnose, but it is difficult to treat.
Makes sense. I want to double click on a few of those things just to we kind of dive in a little bit deeper. So first of all, with the medications, you mentioned SSRIs, so selective serotonin receptor inhibitors. So we're talking about Paxil, Prozac, some of the most common antidepressants on the market. So that being said, it's not affected by all antidepressants. It's not the concept that you just have depression and you're taking this medication. It's the actual medication that's potentially affecting it.
That's right. And again, this comes down to sort of the neurochemistry issue, right? Because these medications, they'll help your depression. They're not going to help your sex life because they're one of their most common side effects in men in particular is anorgasmia, right? Because they promote that serotonin presence, which can be an inhibitor to the system.
Now, one thing you can see online, I guess, is that one of the medications that you didn't mention was opiates, right? Like pain medicine and stuff. A lot of people, unfortunately, are having problems with pain medicine. In your practice, have you seen this as a big issue with people who are taking chronic pain medicines?
Yeah, I absolutely, and that I'm glad you brought that up. That was a class that I had forgotten, and to be clear, on the other side of the aisle in terms of premature ejaculation, using tramadol, which is a weak opiate, is a way to extend what we call ejaculatory latency time, or your time to ejaculation, right? So similarly, on the delayed ejaculation side, opioids are absolutely a potential contributor. But again, as I said, the drug related causes of delayed ejaculation are probably among the easiest to sort out because you kind of go down the list, and if there's a medication that could be contributory, then you have that discussion and you either change it or you try to treat through it.
That makes sense. Yeah, it's easy to know if you're on a medication or not. That's for sure. Now, let's say they're not, right? Let's say that, okay, I'm not on any of these medications, so I can check that off the list. In terms of the hormonal issues, right? So you mentioned low testosterone, you mentioned low thyroid levels, you mentioned prolactin, which is produced in the brain as well. Are there any, not to play doctor, and that's not something I encourage the guys to do at home, but are there any other signs that there might be a hormonal cause to this?
A great question. So, let's touch on two of these. Let's talk a little bit about thyroid, and let's talk about we can talk about prolactin. That's a bit tougher, and we'll talk about testosterone. So, from a thyroid function standpoint, and this also does apply to testosterone or a condition called hypogonadism. Guys typically present with more fatigue, right? So they are in the setting of both thyroid and testosterone. They're more tired, they get tired more easily, they're tired earlier in the day. They start to gain weight even if they are working out, they're not tolerating workouts as well. Those are some potential signs. And I say potential because they're very non-specific. Like you actually have to, at that point, you have to say, you know what, something's not right with me as the patient. You have to go seek out somebody, like myself or another person who treats these conditions. And then you have to get tested, right? Because the way you diagnose these is with blood-based testing for both of those conditions, right? For prolactin, the prolactin's an interesting one in the sense that what we know, there's more that we don't know than we know. And what we know, and the reason that prolactin, quote unquote, rises to the occasion when it comes to involvement in orgasm is that after men orgasm, they have a prolactin surge, meaning right after ejaculation and orgasm, their prolactin levels go really, really high. And those are associated with what we call the refractory period, which is the period of time, like, when you're a young guy, you're kind of like, well, how many times can I do it with this girl in one night, right? It's your refractory period that really determines that, which is how long it takes from you to go from one orgasm to being able to get erect and ready to go for your next one, right? And that's correlated with prolactin levels going up and then coming back down. So prolactin may be associated, high prolactin may be associated with delayed ejaculation. And the way you assess that is in some men, especially those who have a tumor in the gland that hangs down from your brain that produces prolactin, they start getting some visual field defects, some things like that. That's much more of a telltale sign than what I'm going to say next, which is a lot of times you don't even know, right? And and so you again have to test for, for prolactin levels, which 99.9% of the time in the guys that I've treated are in the normal range, right? So there's no perfect assessment there when it comes to those specific conditions. The other things, though, very practically speaking, that can contribute include diabetes, right? And other conditions that can lower testosterone levels, right? Because low testosterone doesn't just happen, right? It can happen. Like, one of the ways in which low testosterone happens is you get older, right? Like, we've seen some evidence that once you hit about 30, 35 years old, your testosterone starts to decline about 1% per year. Jury's still a little bit out on that, but by and large, there are other contributors to low testosterone. There are other conditions, diabetes, there's the environment, there's stress, there are other aspects of your life that can contribute to that. And those can have secondary impacts, like we're talking about, on one's sex life.
Got it. No, that helps a lot, actually, for guys, to give guys perspective on what else to look out for. Now, obviously, the psychosexual issues, those are hard because that requires a lot of insight that guys don't generally have on a day-to-day basis, whether it be anxiety or fear or whatnot. But we'll dive into that a little bit later. You also mentioned hyposensation, meaning they don't feel the penis enough. And you mentioned injuries or surgery, and also diabetes can cause that as well. I'm assuming that decreased sensation is not just during sex. They would potentially have some decreased sensation, generally speaking, like around the whole area of the pelvis, or not really?
They might, and it's a great point to bring up, in the sense that, that many men, particularly if they're, and yes, with diabetes, you sort of expect peripheral neuropathy, like peripheral in the feet and hands, before you expect. And I'm not a diabetes expert, but this is sort of, been what I've generally been told and seen, before you expect it in the penis. It doesn't mean it is what happens. That's one aspect of it. Two, many times, guy and people in general can have decreased sensation, especially if it's located to the sort of pelvic or, genital area, and not really even notice it, right? Like, they would need to get, testing to, or go to a neurologist or a urologist who's experienced in this area, to really sort of say, hey, you know what, things aren't quite right there, right? And it typically doesn't. I mean, it doesn't happen spontaneously. Like, you're not going to have decreased genital sensation just cause, like,
Right.
something happened. You had an insult, you've got a slipped disc. There are reasons that you can kind of go down the rabbit hole and explore for that. I think the other thing are other neurologic diseases, right? So, like, multiple sclerosis is a good example, and this happens in men and women. And obviously, multiple MS happens more frequently in women, but one of the presenting symptoms in men can actually be decreased genital sensation, depending on where the lesions are in the spinal cord.
Got it. No, that's excellent to know. Now, you mentioned decreased sensation, but also something, this is kind of interesting that I want to dive in a little bit. If you look online and you look about this delayed orgasm, you hear about a lot about hyperstimulation, meaning men that engaged in excessive masturbation. Now, when you're a kid and you hear about the hairy palms and don't do this and whatnot, and you thought, hey, this is a myth, and all of a sudden, here we go. Now the masturbation specter comes in again. Is this real, or is this really contributing, or is this kind of more myth of Google going on?
Yeah, it's a good question, because Dr. Google can be both a boon and a bane, right? So there is some evidence that use of pornography, masturbation, and I think it's called idiosyncratic masturbation in technical terms, but aspects of, I'm not going to call it sexual deviation, right? Because that's not the right term, but not quite normal sexual practices can decrease sexual desire, right? Because it's resetting of expectations in sex in a way that isn't, I shouldn't say unreasonable, but in some ways unreasonable, because what you see on TV or on Pornhub or wherever you end up going for this is not going to reflect real life 99.9% of the time. And there is definitely some evidence that supports that supports a lower sexual desire, not necessarily a direct link to delayed ejaculation or anorgasmia, but some aspects of worsened sexual health because of those types of practices. Now, the positive thing about that, we alluded to this earlier, is that guys can be helped with this, right? And either they do it alone, or they can work on it with their partner and or psychotherapist, sexual therapist. But there are ways to fix these type of things. But admitting that you have a problem in the first place and then running that to ground can be a challenge.
No, that makes a lot of sense from the pornography aspect, because again, you kind of get desensitized. You're expecting a lot of exotic stuff, and then plain vanilla sex is just not that interesting anymore. But on the flip side of that, just in terms of masturbation and hyper sexual activity, can you use it too much? I mean, we all know you can break it, but can you use it too much where it's just kind of nerves are damaged, or it's kind of injured in that sense? But that's not, I'm assuming that's not the issue here.
Yeah, Oleg, you bring up a valid point in the sense that guys can definitely hurt themselves, right? It really depends on how far you go, right? I mean, I've had patients who were masturbating by, ramming their erect penis into a wall, right? I mean, literally, like, and in that case, to your point, yes, you can actually hurt yourself. But, if you're engaging in these practices but not physically causing damage, it's unlikely.
Got it. Now, I'm just going to throw this out there. I don't know what the answer will be, but guys always like to know this. Is there anything? So I'm a guy, I'm sitting at home, I'm listening to this. I'm like, this fits me to a T. I'm not quite sure what's causing it. Maybe it's anxiety. I don't know. Is there anything I can do at home? Is there anything I can do without seeking medical attention to address this issue first?
Potentially, and I say potentially because I'm not trying to play doctor to everyone. And I say potentially because it really depends on what the cause is.
Right.
So for all the things that we discussed initially, the physical or physiologic causes, so the hormonal disorders, the physical stuff, any sort of trauma, stuff that where obviously damage has occurred, and now you have a problem as a result. No, you probably need some treatment for that. If it's psychosocial, and you've got a partner that stresses you out, or you stress out over your partner, then yeah, potentially. I will tell you though, the reason that podcasts like this are really important is normalizing the issue across more and more men, right? Making them more comfortable in realizing that they have a problem, they think they have a problem, they want to have it addressed, and that there's help out there, right? So I wouldn't expect the typical man, and myself included in this, to sort this out himself and say, oh wow, I think a big part of my problem is my partner, let me work on this with him or her, right? It's more typical that they'll hear something like this and say, oh yeah, this is an issue, let me maybe go find help. But to answer your question, yeah, when it comes to the psychosocial aspects, maybe, but by and large, having the help of an experienced clinician in the space, whether they are a guy like myself or a sex therapist, psychotherapist, or other type of physician, that's really how you get the goal.
Well, that actually leads to my next question. So guys are nervous enough about this, right? They don't want to see multiple people. Is this a problem that they're going to see their primary care doctor to? Do they, obviously it depends on their insurance. So let's take that aside. Who is best qualified to be the gatekeeper or the initial triager, let's say, of this problem?
Yeah, no, it's a great question. I would probably tell you, look, I'm going to be fairly blunt about this, in the sense that not too many clinicians know very much about this, right? And I would actually go so far as to say, even people like me who do this, who take care of patients like this fairly frequently, we're also in the dark, because like we talked about in the first 20 minutes of this podcast, we don't know what causes this half the time. So, my advice is, go find the most experienced person that you can on this. Can you talk to your PCP about it? Sure. The chances that they would be able to do something about it are slim to none, right?
Right.
Because the chances that I'm going to be able to do something about it are relatively low, and that's just because the data and the treatments available are incomplete.
Right. No, that's a good point, because the problem is that guys go to their primary care doctor, and I've seen this in referrals too. They go to their primary care doctor, and it's just really frustrating because the primary care doctor is just, listen, I can handle your diabetes, but I don't even know which end is up with this. And then a lot of urologists don't even feel comfortable with this, because they're like, yeah, if you have erectile dysfunction, I'll give you something for it, but like delayed orgasm, I mean, most urologists, correct me if I'm wrong, will tell them, you know what, they're psychological, you're depressed, and you got to address that potentially.
Yeah, and that's right. And so the one line message is find a specialist who is fellowship trained in men's sexual and reproductive health. Those are going to be your best bets, at least in the United States, and I would say globally as well, to be able to help you, particularly with this condition, which we opened up saying it's one of the least understood and most difficult to treat men's sexual health issues.
Now, we just had a talk on Peyronie's, and the expert then mentioned about, I think it's the Sexual Society of North America. Is that a good site to go on to find that expert, or do you recommend another one?
No, it's a great point. So, well, it's funny because this kind of comes full circle, right? So, Sexual Medicine Society of North America, or SMSNA, they have a great patient-facing website. I haven't been on it in a little bit. I've worked on some of the content there, but their website, I think it's called Sex Health Matters, and I forget if it's .net, .org, or .com, is their patient-facing website where you can find real information, not fake information, written by experts in sexual health, for men. The other thing, and I'm really glad you brought up SMSNA, is that they also have a physician finder on that website, which helps them find in their geolocation, practitioners who are typically SMSNA members, because anybody who really has a vested interest in this space is an SMSNA member, who are as close as possible to them, who could have a much higher chance of helping them than, certainly, as you said, their GP would.
No, that's very helpful. We'll put that in the show notes. We'll put the links in the show notes so the guys can do it, because that's the other thing. Listen, it's all good to be motivated to go, but then where do you go? And you're going to go to hit a brick wall, and then guys will get frustrated pretty quickly. Now, that being said, I know guys just like you do. We see them quite frequently in clinic, and this is not a topic they're excited about going to see the doctor about. They're nervous, they're anxious, they don't know what to expect. And part of that is just that anxiety. What are you going to do to me? What are you going to ask me? How embarrassing is this going to be? So I just want to kind of distill this down to kind of the logistics. If somebody's coming to you for a consultation for a delayed orgasm, what do they expect? First of all, like, what kind of questions are you going to ask them?
Yeah. So, and I have a couple of points on this. So let's put a pin in. Let's talk about giving patients access to this, maybe outside of a physical clinic, right? And enabling through telehealth. But to your point, you're right. I mean, so guys, in terms of expectations around a visit, right? What you should expect is a lot of questions, right? But it's primarily going to be questions, right? Because again, the diagnosis of delayed ejaculation is really based on how long does it take for you to ejaculate, right? And a lot of times guys will have difficulty answering that question. Delayed ejaculation is a lot easier than premature, right? Because premature is really defined on stopwatch based times, and most guys, they're going to hand wave, right? They're not going to look at their desk clock. But a lot of times, a guy will tell you, hey, I'm going for 60 minutes and I'm tired, she's tired or he's tired, and we're not getting it. Right. But again, just to finish off on the, the evaluation. So it's a lot of questions, we'll talk about medications. We'll talk about any sort of medical issues, any sort of interventions, traumas, all the stuff that we've already covered today. There may be an exam, right? And that really is driven by, just completeness. Like, you don't want to miss something just because you didn't do an exam, but more importantly, also by history, right? So if a guy says, well, listen, I was in I fell on a railing from 20 feet up and all of a sudden my penis doesn't work anymore. That's more likely to prompt an exam than, a guy sort of saying, well, yeah, I started taking this medication and, 2 weeks later I couldn't ejaculate to save my life. But by and large, that's the main component of a visit. There may be some blood testing to our discussion about some of the hormonal issues, but it's very straightforward. A lot of this can be addressed just by having a discussion, right? And that's, I just wanted to also kind of point out that as we use technology more in clinical care to provide care, guys may be more likely to access care when they don't have to actually look a practitioner in the eye in a physical setting, right?
Mhm.
And they're able to do it either asynchronously through, say, a text conversation. We're not quite there yet in healthcare, or through this type of, through a telehealth visit, where you
Mhm.
talk on the phone or you are able to interact via video visit. And I say this because anonymity, especially based on some of the web-based surveys that have been done, not necessarily around ejaculatory dysfunction, but around other areas of sexual health, the anonymity of being able to interact with an expert in that way
Mhm.
opens up doors that we currently take for granted by forcing a guy to come to the clinic. So those are all considerations. But look, if you want to, if patients want to be seen in the clinical setting, then the expectation is that it's going to be a very straightforward visit.
Got it. Got it. I'm sorry. Hold on one quick second. Apologize. So sorry about that. It's kind of like that CNN interview where the kid runs in and the mom chases him down and tackles them. It's kind of same idea here. Uh, that was actually an interesting point about the telehealth and stuff, because I didn't actually think about that, but I think that guys might be a lot more comfortable because there's that level, that barrier in between, that kind of helps as well. So that makes a lot of sense. So it sounds like the physical exam is not a huge thing, which is also makes them feel more comfortable. You mentioned labs, which makes sense for the hormonal part of it. There's a couple of tests that are online. Again, Dr. Google, I just want to make sure we cover them so guys are aware. One
Sure.
is biophysiometry. Can you tell us a little bit about that and how often that's used?
Yeah, so that's used very infrequently. And that's not to say that it doesn't have use. It does, in the sense that that's a more sensitive, sort of machine-based test for assessing penile and sensation more generally, right? There are very few of us in the field who use it, right? But it's reasonable if you suspect in particular, a neurological defect, right?
Mm-hmm.
Um, you're probably also going to ask about imaging.
Mm-hmm.
So imaging, that's a good point. And again, that comes down to where we would suspect the problem is, right? So if somebody comes in with, a neurologic issue, decreased sensation, something over time that would suggest that there is a neurological problem, then a lot of times we would get imaging, an MRI of the, lumbar and thoracic spine, to sort of see if there's any, any physical causes, slip disc, tumor, etc., that could be causing some of these problems.
And that's an important point because so the reason I wanted to bring these up is not so much that I think that they're critical, right? As I think you would agree, they are used rarely and for the right indications. And what I want to make sure guys understand is when they see these kind of cool sounding tests, they say, you know what, I need this, right? Because this is going to be the key that's going to determine. And I think you made an important point is that it really depends on what the doctor thinks the problem is, right? So if the doctor thinks your
That's right.
problem is hormonal or psychological, this test is really not going to do much for you. And it's just kind of a waste of time. But guys oftentimes get tied down to this cool sounding test. And it's like, this is kind of, it's more cutting edge. It sounds high tech. This is something that really should be done for me kind of thing.
Yeah, and that's also a really good point, just to sort of say that, look, what you just talked about is in terms of testing, right? And there's also, I think there's something called potential somatosensory evoked potentials. I mean, it's
Right.
basically like an EEG for your genitalia in some ways. Just sort of tells how well you respond to stimuli. These types of tests are very, very rare. And the reason they're rare is because those types of those types of definable causes for delayed ejaculation are fairly rare. It's very infrequent that we would find, a cyst or a slip disc or something like that on imaging, that would lead to some sort of intervention outside of us trying to treat the condition. But, for completeness sake, in some cases we will do this, but that's definitely not the expectation. The expectation is have a conversation, maybe do a basic exam, look at some special areas, specific areas depending on the complaint, and then move to treatment.
Got it. So speaking of treatment, great segue. Thank you. You've done this before. So I want to jump into treatments for the various categories that we talked about,
Sure.
right? So we'll first talk about, okay, let's say the patients or the guys visiting you, and you think, you know what, this sounds psychological. This sounds psychosocial. What is the next step? Do you refer them to a sex therapist? Is it something that the urologist or sexual specialist themselves would give them therapy? What should they expect for psychologically induced delayed orgasm, or at least the suspicion of it?
Yeah, like they should expect to be referred, because I can literally count on one hand the number of urologists that I know who can deliver sex therapy. Matter of fact, I can count them on one finger.
I was going to say, I'm surprised you got to one hand. I'm like, I'm a loss. So no, sorry, go ahead.
Yeah, no, we happen to have a fellow who is both an MD and then also an MS in sex therapy around this, right? So she's probably the first person that I know that can do both. So no, you should expect to be referred, and then really the approach is dependent on the therapist. A lot of times it will involve the partner, in terms of the actual treatment. I mean, I don't specifically know like categories beyond like cognitive behavioral therapy, versus there's some eye movement based therapies that seem to work well for some aspects of sexual dysfunction. Typically there is some involvement with the partner, right? And so to have that both support from your partner, but also that buy-in from him or her to come and do this part with you as the patient, is really important in most cases. And then speaking to success rates, it's difficult to tell because look, the depth of the issue, especially on a psychosocial level, is very variable. I mean, it really depends on the guy. So, you can be helped in a few sessions, or it might take months. But again, same as when we talked about who do you see for this condition initially, and I said, hey, you want to have a specialist in male sexual health, right? In terms of sex therapists, it's the same thing, right? There aren't that many in this country that do this very specialized work, but they're out there. And typically your urologist, who is a specialist in this, can direct you to the right person, right? Because we typically have those relationships because we need them. We need them to help you.
Right. No, we actually had we had two great top discussions with two different sex therapists, one about anxiety and sexual activity, and the other one just in general in terms of psychosexual issues. So I invite the guys to refer back to them because it can help. In your experience, are these treatments, psychosexual treatments, is this kind of like, hey, do this for 3 months and you're good, or is this kind of a lifetime investment to maintain this?
It depends because, look, in these, a lot of times with psychosexual therapy in particular, practice makes perfect, right? Because you're not going to, the treatment is it involves you as a patient, right? Like the therapist doesn't just wave a wand and your problems go away. There is very purposeful rinse and repeat type approaches to help, right? So part of the outcome depends on how invested you are and how much time you're able to devote, and then also, some of it is also, you need to keep it up. I don't know just how much, but there is an element of maintenance, right? So it's not just like you don't just go through the treatment and then you're done. In some instances you do, but there is a constant like reminder of, hey, let's not kind of fall back on where we started. Right. And again, this is typically a partner. This is it takes two to tango type problem. So both people need to be invested in the solution often.
Makes sense. Now, medications. Obviously, we talked about some inciting medicines that obviously your doctor would have you stop, like those Paxils and Prozacs, and switch you to something that doesn't cause it. If you look online, if you do a search medication delayed orgasm, it'll tell you there's no FDA approved medication currently. But my understanding is there are still off-label medications being used to some extent. Can you tell us a little bit about those?
Yeah, absolutely. And look, you already said the magic words, which is there are no FDA approved therapies, right? And to be very clear in terms of the evidence base for anything, and I mean anything that we would offer to patients as a medication to facilitate or the treatment of delayed ejaculation, um, the studies are fairly scant, right?
Mhm.
So, if you were to come into my office and say, Doc, you know, I need the best possible medication for the treatment of my delayed ejaculation. Which one is it? I would say, I don't know. Right.
Mhm.
Um, but
Fair
to
enough.
back up and answer your question, there are a couple of classes. You already touched on one. So there's SSRI induced delayed ejaculation, right? Where you already touched on one way, which is okay, get off the SSRI, change to
Sure.
something else. If you can do that, great. If you can't, then the antidepressant that you can use to sort of try and treat through it, is bupropion, right?
Mhm.
Sometimes you can swap out an SSRI for bupropion, but if you need to treat through it, you can use that. Try and switch to a different SSRI. If you're dealing with delayed ejaculation with no SSRIs, I mean there's literally 7 or 8 medications out there that may work.
Mhm.
Um, Cabergoline tends to be, one that is a go-to for many of us. And cabergoline, as a treatment for Parkinson's, it lowers prolactin levels. And so the theory there is what we were talking about before. When prolactin levels rise, you may inhibit ejaculation, right? But there's oxytocin as well, and that's sort of thought to sort of just like it does in women, cause milk letdown in the breasts. It's thought to contribute to the onset of orgasm. And so taking oxytocin just before you want to have an orgasm within a couple of minutes is thought to help. Again, evidence isn't great. And then there's kind of, there's stuff like pseudoephedrine, there's midodrine, there's apomorphine, there's yohimbine, which actually has decent evidence. It's not perfect, no real good clinical trials. There's imipramine. I mean, there's literally a list of may work, has some case studies. We will try it because we have nothing really better, but don't expect it to be a miracle drug. That being said, anecdotally, some of these drugs will work 50 to 70% of the time in patients, right? So it's very much not, it's not, it's these are good options to try. And if they don't work, move on to the next one. But they are definitely off-label options.
So a couple of questions about that. Number one, you mentioned the oxytocin is as needed. Are most of those other drugs as needed too, or are they ongoing?
They can be both, right? So for example, we talked about SSRI induced delayed ejaculation, right? So if you switch to bupropion, right, you're substituting an SSRI for bupropion, so that would be an ongoing medication, right?
Mhm.
If they're not on an SSRI, we talked about cabergoline. Cabergoline also would be an ongoing medication. It typically takes a little while, at least anecdotally, for these medications to kick in and start to work. So
Mhm.
staying on them is typically recommended. But there are others that, like you already correctly pointed out, oxytocin. That's on an as needed basis. Just because the levels, you need higher levels in the moment, you don't need higher levels 24/7, right? And it's also a very short acting medication.
And with cabergoline, you mentioned that's the presumed method of action is its effect on prolactin. So is that medication only prescribed if the guy gets a lab test that shows the prolactin's abnormal, or can be used empirically just to try?
It's a great question. So I've used it in both settings, and typically, and again, this is not, there's no strict guidance on this. Typically what we try to do as practitioners, we will definitely test, right? And if the prolactin is low, right, then typically we'll sort of say, no, I wouldn't recommend this. If the prolactin is normal or high normal, then we would certainly try it and see if there's a benefit. Sometimes we get kind of pushed up against the wall, right? Where, we just talked about some drug options, cabergoline being one of the ones that has some of the best evidence. And if we're up against the wall, then even in a guy with, low normal or even low prolactin, it's unlikely to hurt. The side effect profile is very favorable, and so sometimes we'll try it and see what happens, because again, these men are, they're not happy campers, and they will try a lot of things.
And with just finishing up on these medications, so you mentioned 50 to 70%, at least, in your own experience, improvement. How do you define improvement in this situation?
Yeah, it's a great question, right? And again, this kind of comes down to the lack of evidence, right? But typically how I'll define it anecdotally, not having run a study on it, is a guy will come in after you start them on it, and they'll tell you, hey, I'm lasting, half as long as I did before. I definitely feel like things have gotten better. The gap in is just like we talked about earlier. These guys are not using a stopwatch, right? So
Right.
they may be able to tell the difference between 20 minutes and 60 minutes, but they can't tell the difference between 25 and 30 minutes.
Right. But at least subjectively, they feel better. They feel like they're
That's
having
right.
a better, more satisfying sexual experience, because really that's all that matters, right? At the end of the day.
That's right. And I mean, by the book, you'd want to have exact times, but that's unrealistic.
Got it. And obviously, you've mentioned a variety of different medications. Are these, I'm going to put in very technical terms, are these pretty hardcore medications with really big side effects, or are they pretty well tolerated as just a general group, if you want to lump them together?
Yeah, it's a great question. And so I would say it varies, right? So drug like cabergoline, pretty well tolerated. Drug like oxytocin, pretty well tolerated. Drugs like pseudoephedrine, ephedrine, midodrine, like some of these, vasoconstrictive, agonist type drugs, really depends on who you are, right? I mean, you don't necessarily want to give that to like the hypertensive who's on 5 different blood pressure medications, right? Because you don't know what's going to happen. I mean, they are typically well tolerated in the moment, but the sort of serious adverse effect of some of these meds could be serious: heart attack, stroke, that sort of thing. So you have to be careful with that. Apomorphine, most guys don't, that's not typically a drug that's used, right? And it's typically used ex-US, so outside of the US. But a lot of guys don't notice anything. And then some of the others. So yohimbine is, that's more of a supplement, not a drug. Typically well tolerated. So look, by and large, these are all drugs that, they're drugs, right? So they're FDA approved for something. But they do have variable side effect profiles. Nothing has an awful side effect profile though.
Got it. Now, we've spent hours talking about testosterone, hypogonadism, libido, etc. But in this context, if somebody's just presenting with delayed ejaculation, right? They have a good sex drive, they have a good libido, they don't have any of the other side effects or signs of low testosterone. If a guy comes in and you do a T panel on him and it's low, would you prescribe testosterone just for this indication generally?
No, in the sense that, look, this in and of itself, delayed ejaculation, is not really a symptom. It's not a symptom of hypogonadism, right?
Mm-hmm.
So, and it's very rare. It's very rare to have guys come in with just this as a symptom of hypogonadism. That's a nice way of me saying that, you know, I would think twice about giving a guy testosterone just for this.
Mm-hmm.
That being said, if a guy does have bona fide hypogonadism, he'll have other symptoms, so they'll be
Right.
easy to suss out. And look, if you, again, you sort of think of what is the worst case scenario and by worst case, I mean, you get pushed up against the wall. You don't really have other options. You sort of, the guy comes in, he's got low or low normal testosterone. His only issue is delayed ejaculation. Could you try him on hormone therapy for a couple of months and see what happens? You can, right? You're not going to burn a bridge doing it, but you do need to think twice about what is the actual symptom profile, what do the labs look like, and not take it lightly.
That makes a lot of sense. Yeah. Again, the reason for I'm asking is that some guys will go online, they'll see testosterone is related to this, and they'll be saying, "Doc, I need a prescription for T supplementation," and that comes with its own bag for sure. And we don't want to just have people willy nilly on that.
And to your point about side effect profiles, I would say that testosterone has probably one of the worst side effect profiles when used incorrectly of
Right.
any of the drugs that we just discussed.
And risk, absolutely. No, great point. And then the final category is that hyposensitivity. There's a lot about penile vibratory stimulation.
Yeah.
Please expostulate.
Yeah. So look, I mean, penile vibe stim is definitely one of the ways that you can overcome quote unquote insufficient stimulation, right? There are a number of devices out there that guys can buy, and medical practices use too, that deliver a pretty dramatic level of stimulation to the penis that can definitely bring you closer to orgasm. So definitely something to consider. Also in that category of insufficient stimulation, and this really depends, right? Because penile vibe stim, you know, you use that oftentimes when sensation truly is decreased, so a neurological issue, right? There can also be obviously this sort of this if you perceive your stimulation to not be sufficient, you can certainly try it, right? Because you can tick up and down the level of stimulation. But for guys who may have insufficient stimulation and it may be more psychosocial, there's definitely sexual technique training, there's cognitive arousal type, psychotherapy and sex therapy approaches. So penile vibe stim in the setting of insufficient stimulation is not the only way to go. There are other options too.
Got it. And for that vibratory stimulation, you mentioned it can bring them to an orgasm, but that's not something like they do on a daily basis to improve their sensation. It's just to actually orgasm. Or am I catching that wrong?
No, that's a great point, Oleg. You're exactly right, right? It's used in the moment. It's a treatment for the problem at hand. It's not necessarily a solution to the root cause of the issue.
Got it. So last question, and this is one you may not be able to answer, is, guys it always also comes down to cost. This is not a typical medical problem. Is this, in your experience, does insurance usually cover this problem, both in terms of evaluation and probably more importantly, all these off-label medications that are possible treatments?
Yeah, so I would say that typically in terms of the visit, the evaluation, and the sort of blocking and tackling of getting to the point where you're getting therapy, by and large, yeah, you'll be covered for the visit and whatnot. I know that there's been, and I say that not with hesitation, but I say it to the extent that current state is that most insurance will cover the visits and the treatment around this because it's fairly basic. And all of these drugs, none of them are brand anymore. They're all generic. So even if a patient has to be out of pocket for the coverage or one or more of these drugs, chances are that they will be affordable, right? And as we already talked about, there's no surgical intervention for this, right?
Right.
So in general, any patient costs for the evaluation and treatment of delayed ejaculation are going to be, fairly small from a healthcare expenditure standpoint. They can get more expensive if you're starting to do some of the specialized testing, like, if you're starting to get MRIs and whatnot. But again, fairly well covered by insurance by and large.
Got it. Dr. Pastuszak, thank you so much. This has been extremely helpful. I'm sure the guys out there who have been struggling with this will find this very valuable. Before we let you go, we're going to ask you one more question unrelated to delayed orgasm, I believe. The title of this podcast is Better Man Clinics. And so the idea is to help guys live their best life. You've obviously have reached a level of success. That's why you're on the podcast. What's the secret to your success? How do you live your best life? Simple question. Just take 10 seconds to answer.
No, Oleg, I appreciate the question. I live my best life by working to really help people that go beyond one or two people at a time, right? So, I became a doctor because I wanted to help as many people as I could, right? And I found out that I could do that, but then I could help more people through some of the research and, in clinical development work that I do. So, you know, I live my best life towards the people that I serve by trying to help more than one person at a time, but helping one person at a time. And I also lead my best life by taking care of me, right? Because selfishly, I can't help anybody if I'm not in a position to help them, right? So my message to everybody who's listening is, do what feels right to you. I've been lucky to be where I am, but making sure that that you're taking care of yourself and your family and the people immediately around you, really is hand in hand with anything that you do for the broader world. And I'm living proof of that.
That's some great advice to the guys out there. Dr. Pastuszak, thank you again so much for joining us and for your expert insights into this very sensitive but disturbing problem to a lot of guys out there. And to all of you guys watching and listening, thank you for joining us. And remember our mantra here at Better Man Clinics: your best life is a journey and not a destination, and use every day to get just a little bit better. We'll see you all next time.